Hello everyone, my name is Jen Nolan and I'd like to welcome you to our webinar this evening. We are very grateful to Peninsula Hot Springs for sponsoring this webinar and allowing it for it to be offered free of charge. Peninsula Hot Springs is an award-winning natural hot springs and day spa destination on the Mornington Peninsula, just 90 minutes from Melbourne. We will also be having a stretch break during the webinar, compliments of Peninsula Hot Springs. Tonight's webinar is the second last health professional webinar we will be offering for the foreseeable future, although recordings of all our webinars will be available on our website. Starting next year, and in line with Musculoskeletal Australia's focus on empowering consumers through education and support services, we will be offering a series of webinars for a consumer audience. A list of webinars should be on your screens now, and we will be enlisting your support to inform your clients and patients about the webinars. Further information will be on our website shortly and will also be sent to you. We are currently seeking sponsorship for the webinar series so they can be offered free of charge, otherwise there will be a small fee involved. Before introducing our presenter for this evening, I just have a couple of housekeeping issues to run through. Firstly, if you have any technical difficulties during the webinar, please refer to the message box on your screen. You can type a message at any time that will be read by the webinar organiser at Redback Conferencing. If you're listening via the phone, you'll notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, if you are listening via the phone, you may not be able to hear the audio during the exercise break video or some of the other videos, but it will be available on the webinar recording when you receive it. Also, whilst our presenter will answer questions after the completion of his presentation, you can type questions for him at any time. Then I suggest you don't leave your questions to the last minute, as we'll aim to finish no later than 8 p.m. Australian Eastern Summer Time. I'd also be very grateful if all participants could take a moment at the end of question time to respond to our feedback survey. Our presenter for this evening will be Professor Rob Daly. Rob holds the position of Chair in Exercise and Ageing within the Institute for Physical Activity and Nutrition at Deakin University in Melbourne. He has over 20 years of experience in conducting human, clinical, public health and translational intervention trials to evaluate the role of exercise and nutrition for preventing and managing common chronic diseases such as osteoporosis, sarcopenia and falls. He has been an active contribution nationally and internationally to clinical guidelines in the area of exercise, calcium and vitamin D for osteoporosis prevention. He is a council member of the Australian and New Zealand Bone and Mineral Society and the Australian and New Zealand Society for Sarcopenia and Frailty Research, a fellow of Sports Medicine Australia, a member of the Victorian Allied Health Research Network, and a member of the Medical and Scientific Advisory Committee for Osteoporosis Australia. He is also founder of the Osteo-sized Strong Bones for Life community-based osteoporosis prevention exercise program. Without further ado, I'll hand proceedings over to Rob. Thanks very much, Rob.
Thank you, Jen, and welcome everyone to this webinar on exercise to prevent frail bones, falls and fractures. So what I'm hoping to do tonight is really provide you with an update on the latest evidence with regard to exercise for optimising bone health and preventing falls and fractures. So we currently know about 4.7 million Australians have osteoporosis, but perhaps osteoporosis is really not the biggest concern. The concern is the people that go on to have a fracture. And so this slide shows you some startling statistics from Australia showing that in 2013, one fracture occurred every 3.5 minutes, or 395 fractures per day were recorded. And if we don't really do anything to prevent this increased prevalence or incidence of fractures, we're going to see one fracture every 2.9 minutes. So that's 500 fractures per day. And so we know it's a serious public health problem. We know that particularly hip fractures are particularly devastating. Up to 20% of people will die within 6 months of sustaining a hip fracture. I guess what is more startling is that currently 80% of people that actually have an osteoporotic fracture are not identified or not treated. So many women in their 50s or 60s, or even men, if they suffer, for example, a wrist fracture, they're often treated for that fracture and it's mended, but people don't think that this person may be at risk for osteoporosis or even have osteoporosis. And the other important point to consider is that sure, osteoporosis increases your risk of having a fracture, but Australian statistics also show that 30 to 50% of women aged over 60 that do have a fracture actually don't have osteoporosis. They have osteopenia or low bone mineral density. And so just because you've got osteoporosis doesn't mean that you're going to have a fracture. It just means you're at increased risk of having a fracture. So if you've got osteopenia, which would consider that you don't have osteoporosis or really low bone density, then there's clearly other risk factors that we need to consider. And so what I'd like to do with this webinar is provide you with, I guess, another understanding on some of the non-skeletal risk factors for falls and fractures and which factors should we really be targeting. I'll then go over some of the new evidence related to the optimal type and dose of exercise to enhance bone health and reduce fracture risk. And then I'll talk about some of the new evidence around exercise to optimise muscle function and reduce our risk of having falls. So the reality is for people with osteoporosis, drugs are the first line of treatment. And we know that various pharmaceutical agents to treat or prevent osteoporosis can have an effect or reduce your risk of fracture by about 20 to 60% depending on the type of agent that is used. But we also know that compliance with drugs can often be an issue, and this evidence suggests that 50% of people will discontinue their treatment after 6 months. Obviously, in recent years, there's been concerns around various side effects associated with very osteoporotic drugs. We also need to consider that these drugs are not prescribed to people with osteopenia, when we know many of those people will actually have a fracture. And I guess the most important point with these osteoporotic drugs is that they are designed specifically to target bone, but they don't improve any non-skeletal or falls-related risk factors. And that's where things like exercise or other lifestyle factors can play a really important role. And so we're all well aware that we lose muscle with age, and this is a fantastic illustration of the cross-sectional area or size of our muscles in our thigh and what happens as we go through age or get older. So you can see the size of the muscle decreases in size, and it also becomes infiltrated with this fatty tissue, which can be quite harmful for a whole lot of cardiometabolic sort of outcomes. But it's not just about the size of our muscles, it's about whether they're functionally capable to move and keep us having the ability to do everyday activities of daily living. So here was a nice little study showing your relative risk of having poor physical performance or functional limitations or disability if you had low muscle mass compared to if you had low muscle strength. And so what you can see in the light blue bar is if you've got low muscle mass, so that's like the size or the mass of your muscles, you've got about a 1.4-fold increased risk for poor physical performance or disability. But if you've got low muscle strength, their risk increases up to 2.2-fold. So muscle mass is certainly important, but we also need to ensure that we maintain our muscle strength. And so as you'll see this video play, you'll note that many people will fall over as they get older. And falls are the most common cause of fractures. And so you can see this particular gentleman, as he's walking, and the challenge is trying to walk with his dog, he falls sideways onto his hip. And we know that a sideways fall onto the hip in particular markedly increases your risk of having a fracture. And so falling on the trochanter, for example, you have a 30-fold increased risk. And so obviously the strength of your bones is important, but maintaining functional capacity is critical to stop yourself falling over. So this person, this gentleman may actually have okay muscle size or muscle mass, but he may have impaired strength, but he also may have other factors of impaired physical function. And so when we think about bone strength and bone weakness, this sideways fall, this falling onto your hip sideways is really important because this slide illustrates areas throughout the hip which have low bone mineral density. And so the picture with the yellow highlighted region on the hip has been identified at a very focal region of interest or focal region of weakness, where people that have a hip fracture have really low bone density in that region. And then you can also show on the red, it also shows on the red region, the top part of the femoral neck in particular is very thin. And when we fall backwards, fall sideways onto the hip, the greatest forces occur on the top part of this femoral neck. And so this is really why we need to look at strategies which can improve specific, perhaps regions of interest around the hip if we want to prevent hip fractures. And we know that if you give people a pharmaceutical agent or a drug, it doesn't really know to improve bone density at the top part of the hip. It's just going to result in a generalized increase in bone density, whereas exercise, for example, has the ability to, if it's very targeted, to improve specific areas of interest. And so just to highlight the importance of function to fracture risk, this was a very nice study looking at your risk of having a hip fracture by your level of physical function. And so you'll see in this particular graph, they looked at chair standing ability, leg power, gait speed, and grip strength, and they divided people into different levels of functional ability. So if you were in Q1, you had the highest level of chair standing ability. If you were in Q4, you had the lowest impaired function. And so what you can see here is that people who are in the lowest quartiles or the lowest categories of each of these functional tests were at much higher risk of having a hip fracture. And this was independent of their bone density. So it really didn't matter if they had osteoporosis or osteopenia. If they had the poorest function, they were at a higher risk of having a hip fracture. And so this is really brought upon this new emphasis that when we think about trying to prevent fractures, sure, it's important to consider our bone density or our bone health, but we also need to consider our muscle health. And this new concept called sarcopenia has really grown enormously in recent years in that we now have a definition for it, being that it's characterized by a progressive loss in muscle mass, strength, and function. And we are now moving towards clinical criteria to actually diagnose it. So it's really like osteoporosis for bone, but this is all related to having low muscle function or muscle mass. And so currently there's a little bit of conjecture around how we clinically diagnose sarcopenia, but the European working group have just released some new guidelines in terms of how we could define whether someone is sarcopenia. And so the new guidelines suggest, first of all, you complete a screening tool called the SARC-F, which I'll highlight in the next coming slides. And then you assess someone's muscle strength. And if they've got low muscle strength, you measure their muscle mass, and that's their appendicular muscle mass. So that's the mass in their arms and their legs. And then you can also measure gait speed or some other measure of physical performance or function to see whether they've got severe sarcopenia. So in this next slide, I'll illustrate this algorithm which they're proposing to define sarcopenia. First of all, I just want to highlight the screening tool that they're proposing to use, and this is called the SARC-F questionnaire. So it basically consists of 5 questions that people can do in a couple of minutes, and once you go through the battery, if a person scores at least 4 on each of these questions, they'd be considered at risk of having sarcopenia. So they're not actually diagnosed as sarcopenia, but they may be at increased risk. So it's a very simple tool, very simple screening tool that we could easily administer to people who you may consider at risk of having impaired function or low muscle mass or strength. But here is the algorithm that they're suggesting that we use. And basically what they're suggesting is that we have a measure of muscle strength, and that can be a grip strength.
The hand grip strength test measures the maximum isometric strength of the hand and forearm muscles to provide a general measure of overall arm strength.
And they're
hand grip
illustrated on the
strength
slide
is an important
as well.
strength for a
Other
variety of
measures
activities of
physical
daily
function
living and
include,
recreational activities in which
a simple
hands are
sit-to-stand
used.
Test.
Patient
we can remove
instructions.
this video now if you like, Yumi.
The subject
And,
holds the
just
dynamometer
leave
in the
the slide up
hand
there,
to
that's
be
probably
tested.
easiest. Thanks. And other measures that we can use are the chair standing test. So you basically do 5 sit-to-stair stands, and if you can't do it within 15 seconds, then that might be indicative of low muscle strength. So if people are classified as low based on these criteria, we then measure their muscle mass through a DEXA machine, and as I mentioned, we look at the mass in their arms and their legs. That's what appendicular lean mass refers to, or ALM, and you can see there are specific cut points here. There's also cut points where they divide the muscle mass divided by height, very much like body mass index, and there's specific criteria or cut points which would indicate whether someone might have low muscle mass. And finally, if they had low muscle strength and low muscle mass, we could measure either gait speed or a simple timed up and go test, or the 400-meter walk test, or the short physical performance battery. And again, the specific criteria which would dictate whether someone would have impaired functional capacity. But what is perhaps missing from these measures is the concept or the performance characteristic of muscle power. So muscle power is the ability to produce force quickly. And so you've all experienced, being on a train or a tram, and it all of a sudden takes off, and your immediate response is to move your leg quickly. So you don't need to be really strong to do that. You don't need to have big muscles to do that, but you actually need to have what we call force times the velocity. So a bit of strength and movement speed to stop yourself falling over. And we know that muscle power, or the ability to produce force quickly, decreases linearly from about the age of 20 or 30. So we know that muscle mass and muscle strength tend to plateau up to about the age of 45 and then slowly decline. Our power tends to decrease linearly if we don't do much. And it's real strong, and it's a really good predictor of disability and impaired functional capacity. So when we think about the pathogenesis of osteoporosis, most of our traditional thinking has certainly been around muscle mass or bone strength. So we look at, do you attain an adequate peak bone mass in the first 20 or 30 years of life? How much bone do you lose during menopause or throughout older age? But we need to shift our focus. It's not just about bone. We need to think about what's happening to our muscle and what's our falls risk. Because remember, most fractures, particularly hip fractures, occur as a result of a fall. And this has really led to this new concept, what is people refer to as osteosarcopenia, meaning that often people at risk of osteoporosis have low muscle mass, strength and function as well. And so we need to target both the muscle and the bone really to optimize our outcomes. So this brings us to the key aspect of this presentation, is exercise, and which exercise should we prescribe to really optimize our bone health, our muscle health, our function, and prevent our risk of having falls. Now let me first say, any exercise is good for you. Anything is better than nothing. But if we really want to optimize musculoskeletal health, we need to be more targeted in our approach. And so we're moving, and many others are moving towards this concept of exercise is medicine, and it should be prescribed like medicine. So rather than just telling people they should be physically active because they're going to get health benefits, if people have got osteoporosis or osteopenia or have had a fall, we need to be more prescriptive. We need to give them more information specifically about, well, what type of activity should I be doing? How often? What's the frequency and the intensity of activity? Is there specific equipment I should be using which might enhance the benefits? Are there any going to be additional benefits if I consider nutritional strategies or perhaps some other pharmaceutical agents which might enhance the response? Are there any side effects or risky type exercises that we should avoid? And so that's where I think we need to move to, especially as health professionals. We need to consider, particularly for people with various chronic conditions, a very targeted approach to get the biggest benefits. And so now I'll move on to what is the optimal exercise for bone health. And historically, walking has been prescribed for multiple health outcomes for many people. And there's no doubt that walking is fantastic for cardiometabolic, cardiovascular health outcomes, for improving aerobic fitness. But unfortunately, walking is not fantastic for stimulating bone density or maintaining really, or trying to increase our bone health. And this is sort of illustrated in this meta-analysis, so a summary of a whole lot of individual studies which have looked at the effects of walking on bone density at the hip and the spine. And so if you look at this particular figure, if anything crosses over the vertical line, or the individual studies, the horizontal lines crosses over the vertical line, it means the study was not effective. And essentially, if you look at every single study, most of them that included walking had no effect on bone mineral density. Now, there is some evidence that very brisk walking, hill walking, can result in a maintenance or small gains in bone density, but after a given time, the benefits seem to plateau out. And the reason And there's good reason why we don't see a benefit in bone density with walking. And I'll just explain this in the next slide. So this is a very microscopic view of looking inside your bones. And inside your bones, you have these little finger-like or black projections, which are called osteocytes. And these little osteocytes are embedded within our bones, and all the little finger-like projections like to talk to each other. And these little osteocytes are what we call strain-sensitive cells. And so when you do a given activity, if it's of a sufficient magnitude or intensity, it stimulates those little like cells with their finger-like projections to talk to other cells on the bone surface to go, gee, we need to do something here because the bone is being loaded and we need to make sure it maintains its strength. So let's cause an osteogenic response or try to improve our bone health. And so the reality is these osteocytes are fabulous gossipers, but you have to arouse them. And so, for example, walking, your bones and your body is used to walking. It's an activity that we do on a daily basis, even if it might be for short periods of walking. It's an activity that we do on a daily basis, even if it might be for short periods of time. And so your bones become accustomed to that. So as a result, these little guys don't get aroused, and therefore they don't send signals out to the bone surface to cause bone to form. So this is really the basis for understanding whether a given type of exercise might improve or stimulate an osteogenic response or a bone building response. And so again, here is the evidence looking at the effects of resistance training alone on bone density in postmenopausal women. So if you look at the top part of the graph, again, a whole host of studies have looked at the effects of resistance training on changes in bone mineral density, and you can see the findings are really mixed. In fact, this particular study concluded that there were no significant benefits for resistance training alone on bone density, but if you did resistance training with weight-bearing exercises, you did get some added benefits. And I'm a strong advocate for resistance training because resistance training is the most effective strategy to improve your muscle mass and strength. And there's no drugs on the market to improve your muscle mass or strength currently. And so resistance training is clearly the best strategy. But many of the studies looking at the effects of resistance training on bone density have been mixed, and partly because they have been poorly designed. And so when I go back and look through the literature at the studies which were ineffective, the reasons many of them were ineffective is because they had a really poor training dose, they lacked progressive overload, in other words, people did the same thing continually, and as a result, our osteocytes got tired and didn't think they need to form any more bone. And probably the most critical factor is they lacked exercise specificity. In other words, the program was a very generalized program and didn't specifically target muscles around the hip and the spine, which were the key regions they were trying to improve. So there's some very nice work in recent years which have tried to look at different types of exercise and look at where the strains are actually being placed on the hip. And so this is what they call computational modeling. It's very advanced sort of techniques, but they give these little heat or color contour maps with different types of exercise and illustrate if you're going to walk or if you're going to hop or you're going to jump, where are the greatest loads occurring on the hip. And what this particular study showed was that hopping type exercises in particular were quite effective for loading the top and the bottom part of the femoral neck, the region we really want to improve because that's where we know fractures can occur. But what this particular study also illustrated, if you look on the far right-hand side, or it might be left-hand side for you, with resistance training in particular, so hip abduction, adduction type exercises at relatively high intensity, they weren't that effective at loading different regions of the hip, which was quite surprising to me because we thought these types of exercises would be really effective. But the loads or the strains on the hip were actually relatively modest from this particular study. So maybe that explains some of the findings for resistance training where we're not seeing large changes throughout the hip because it's not particularly loading, particularly that femoral neck region. A key factor when we're considering resistance training is intensity, and intensity of training is an important variable when we're prescribing resistance training. And this was a nice study being conducted up in Queensland by Belinda Beck, where she's prescribed very high intensity resistance training to women with osteopenia, or even some of them had osteoporosis. And so all they basically did was prescribe these 4 different exercises. And you can see they are very, I guess, high intensity type activities which require a great deal of supervision. And in fact, in this particular study, 25% of the women were not eligible to participate in the study because they had contraindications to exercise for these particular types of exercises. So it's not for everyone, but under strict supervision, people can tolerate these types of exercises. And as you can see, she saw some nice changes in both the hip and the femoral neck from doing this particular exercise program. I guess just to illustrate the point about doing very targeted resistance training, so making sure you're designing exercises which specifically load the hip or the spine. Here's a very nice study where all they did for these women was back extension exercises which were loaded with a little weighted pack, 10 repetitions at home, once a day, 5 days a week for 2 years. And what they looked at on the top graph is their muscle strength after the 2 years, and then they followed them for 10 years to see if the muscle strength was maintained. And so you can see those that did the back extension training had a much bigger increase in their muscle strength in the first 2 years, and the benefits were maintained up to 10 years, even though they may not have continued with the back extension exercises. And during this period, they were also able to look at how many of these women actually suffered a vertebral fracture. And as you can see on the bottom part of the graph, the number of women that had a vertebral fracture was markedly lower in the back extension group. Now, I'm not saying we should be prescribing this particular exercise to all women to prevent vertebral fractures, but I'm just highlighting the point that very targeted exercises are critical if we're trying to optimise bone health at the hip and spine, or it might be the wrist as well. So here's an illustration of some of the targeted exercises that we've implemented in a number of our community-based exercise programs. And so you can see a lot of our programs, we do try to do resistance or strengthening activities where people are standing and not necessarily always on a machine. You know, the leg press machine or exercise is particularly good, but many of our other exercises, we try to make them multimodal in the sense that you might get some benefits in terms of resistance and loading, but you might get some functional benefits as well. I should just point out the lat pull down or overhead exercises. We do find or do try to avoid a lot of overhead exercises for older people because they tend to experience, or some people do experience, rotator cuff type issues. I'd also like to highlight it's not just about the amount of resistance or the loads from muscle, but it's about the impact loading. And so weight-bearing impact activities are particularly beneficial for bone. And I hope you can appreciate that the osteocytes are not typically used to weight-bearing jumping type activities. And so when you do those activities, they can stimulate a response. And this particular study was done in athletes involved in a whole lot of different types of sports. So high-impact sports, what they called odd-impact sports, which involved a whole lot of change of direction, high-magnitude sports like powerlifting, or just repetitive low-impact sports like endurance training, or non-impact sports like swimming. And what it really highlights is that bones like stress and they like unusual distributions. And what this showed around the femoral neck in particular, the high impact and the odd impact sports were particularly effective at improving bone mineral density. Again, here's some illustrations of the targeted weight-bearing exercise programs or activities that we've implemented in a range of different community-based programs. What we do recommend is, for most people, especially if they've been inactive, you don't start with a high number or many weight-bearing impact exercises. They do find that they experience some muscle soreness, and some people experience joint pain or joint soreness, I guess I should say, if you do introduce this too early into the program. So often we do is do strengthening exercises, and then we slowly introduce the weight-bearing exercises as people can tolerate them. And clearly, women with incontinence issues, we need to be careful about weight-bearing exercise as well. In terms of what type of weight-bearing exercises you prescribe, we're starting to get some evidence showing that, or quantifying the different loads for different types of weight-bearing exercise. So in the little table, you can see, for example, that a lunge exercise is associated with about 1.1 times body weight, whereas if you did a hopping type exercise, it's 3.4 times body weight, whereas if you did various types of jumping, it can be up to 5 times body weight. So this is quite informative when we're designing our exercise programs, because we don't want to overload a person that can't tolerate a different type of activity, but we also want to understand how we can progressively make activities more challenging. And one important point to consider is we don't want to make them, the activities just increase in magnitude all the time. Sometimes we can increase the rate of force or the rate of loading to make things very rapid. For example, like the foot stomp exercise, is a very high rate of loading activity. It has the same ground reaction force as the jump. You can see the rate of loading is 473 compared to the jump 67. So that's applying loads very rapidly. Some very nice evidence, again, using these advanced musculoskeletal modelling techniques, and I won't go into the detail from this study, but what they did with this modelling, they actually looked at different types of activities, such as walking, fast walking, jumping, and climbing up and down stairs, and looked at which muscles were particularly important for loading different regions of the hip. And the key message from this particular study was that the gluteal muscles in particular generated the greatest strains on the femoral neck, particularly the anterior and superior part, where, again, remember, that's the weakest part, which tends to have an increased risk of fracture. So if we're designing exercise programs, let's think of exercises which focus on the gluteal muscles, which might help load different regions throughout the hip. Now, the other important point to consider with regard to weight-bearing impact loading is you don't need a lot of impact loads. So here was a study where they got a group of men who did 50 jumps per day on one leg, and their other leg served as the control leg. In other words, they didn't do the jump. So they basically hopped on one leg. And that's all they did, 50 jumps per day. And you can see the top part of the graph, anything on the hip which shows a change in color, like the blue or the green, means they had an improvement in their bone mineral density. And what this particular study showed was that jumping on one leg resulted in localized gains in their bone density of about 3 to 7%. Now, typically with exercise programs, we see sort of 1 to 3% changes when we look at the whole hip. But if you look at specific regions through the hip, you can get much bigger changes. If we look down at the trabecular bone density, down the bottom leg, up to 12% changes in specific regions of the hip. And so we're probably underestimating the benefits of exercise when we just look at a whole DEXA scan of the hip, because we're looking at the whole region combined and not specific regions where you might get the biggest benefits. I also just want to highlight, because people are concerned about high impact exercise for cartilage. So this was a nice study done in Finland where they did 12 months of impact exercise trying to look at the effects on bone density, but they took these fancy images of the cartilage throughout the knee, and these were in women that had mild knee osteoarthritis. And the take-home message was that the impact exercise helped maintain or result in a bigger benefit relative to the control group at their femoral neck bone density or bone mineral content, but had no adverse effects on their cartilage whatsoever. We've done a whole host of programs looking at multimodal exercise programs, so a combination of resistance training with balance training, with weight-bearing impact exercise program. This is a trial we did several years ago where men were enrolled in the study, and we looked at whether a calcium vitamin D fortified milk product could enhance the benefits of exercise. So we had a group that did exercise with the calcium fortified milk, a group that did exercise alone, a calcium fortified milk group alone, or control group. And if you look at the graphs, you can clearly see that doing exercise resulted in benefits in terms of their femoral neck bone mineral density and their lumbar spine bone mineral density. The milk didn't actually enhance the benefits, and we found out after we completed the study that these men already had relatively adequate calcium intakes and adequate vitamin D levels, so they didn't really need the extra milk. But in this case, we did demonstrate that a multimodal program was particularly beneficial, not only for bone mineral density, but we looked at a whole host of measures of functional performance. Now, it didn't improve all measures of function, but we saw an improvement in gait speed, but we didn't see improvements in various measures of balance. So maybe we need to think a little bit, be a bit more specific in our approach in terms of the balance or functional component for that particular study to improve all aspects. And so as a result of that study, we did design another study, which was really a community-based trial called Osteo-sized Strong Bones for Life. And this was a real-world translational project which we ran out into the community, which was very effective, and then we got some funding with Osteoporosis Australia and the government to trial this in the community. And we did find relatively good uptake, although obviously once the funding went from the government, the program struggled to continue, like many other programs. But central to our particular intervention was we designed this program that would include very targeted exercise program, which I'll highlight in a minute. We also, for people that were delivering the program, there was what we developed an osteo instructor or train the trainers curriculum. So everyone had to complete this train the trainers course before they could deliver the program out in the community. We also incorporated behavioural modification strategies as part of the intervention as well. And all the participants involved in the program were given consumer education and awareness to raise their understanding of the risk factors for osteoporosis, and the importance of calcium, vitamin D and other nutritional factors, and why the exercise program was designed as it is. So here's an example of the exercise program. So again, it was multimodal. We incorporated resistance training, including high velocity resistance training, which I'll talk about shortly. We did weight bearing exercise and challenging balance activities. And we developed all these resources and manuals which the trainers could use and with specific exercises to really target bone, muscle and functional performance. Just in terms of the design of the exercise program, I just wanted to highlight in this particular slide that we do design our programs where they're cyclical. So we have what we call mesocycles and microcycles. So you don't just follow the same program constantly. We change the volume, we change the intensity or the reps throughout every sort of 2 to 3 months for the different components of the exercise program. And the question we often get asked, well, how often do I need to exercise? So in a lot of our trials, we ask the participants to do 3 exercise sessions per week, and on average, they do it twice per week. Now, this particular study was one of the largest studies which has followed women who are involved in an exercise program. It went up to 12 years, and they retrospectively went back and looked at was there a relationship between the level of compliance with the exercise, with their changes in bone mineral density over 12 years. And essentially the take-home message from this multimodal exercise program was that if you did on average 2 sessions per week, you are able to slow or maintain your bone health. And that's typically what we see with a lot of our intervention trials as well. In terms of exercise for very high-risk patients, for those with osteoporosis or a previous fracture, there is not a lot of evidence out there. But in recent years, there's been a group led by an organisation over in Canada who have developed this initiative called Too Fit to Fracture. And they've developed all these resources and illustrations and even videos, which I'll show you at the end of the presentation, about what type of exercises you could prescribe for high-risk individuals. And so here's some examples of specific muscle groups that you might want to target, and just some other factors to consider when you're prescribing exercise for this high-risk group. For example, using short lever arms or body resistance, so making sure people are not reaching a long distance for their weights, which might increase the lever arm and put greater strain or stress on the spine. Again, here's just some illustrations of if you're going to do core stability or strengthening exercises. We just need to be a little bit careful about what we prescribe. So people with low vertebral bone density, we're trying to avoid forward flexion type activities. And here's some great examples of different types of exercises which anyone can undertake, but particularly this group that might be at slightly increased risk. Again, for people with hyperkyphosis or kyphosis, which might be indicative of people having a vertebral fracture, not everyone that has kyphosis doesn't have a vertebral fracture, but this was a nice little study where they got these women to do these various postural and spinal extension exercises and looked at the degree of kyphosis after 12 months. And doing these simple exercises was shown to be effective. Again, a very targeted approach which can have some clinical benefits.
Steph Prem, and today I'm going to take you through my stretch and release program that I've designed for the Peninsula Hot Springs. We're going to be working the entire body, focusing on both static and dynamic stretches, which are beneficial for both body and for mind. We're going to be working on the performance of your entire body whilst improving flexibility and range of motion, whilst also aiding in relaxation and stress. All you will need for this workout is a yoga mat and a positive attitude. Let's get started. Throughout this entire sequence, we want to keep a huge focus on the breath. The breath is so important when you're stretching. You want to inhale through your nose, exhale through your mouth, reoxygenating the blood. Taking your hands lightly onto your rib cage. Inhale that nice lateral breath out to the side. Exhale as you pull the rib cage back down to your center. Inhale out and exhale down as you come back to your center. That's the breath pattern we want to work on throughout all the moves. We're going to start standing nice and tall, feeling your feet grounded into the mat. Imagine you have two lines running straight up through the middle of your body, past your kneecaps, past your hips, up past your chest and out through your shoulders, standing tall with your shoulders pulled slightly back behind you. I want you to drop your chin to chest, and we're going to roll down into a nice spine curl, vertebrae by vertebrae as you roll all the way down, and letting your head relax at the bottom of the movement. Pulling your belly button back to center as you scoop all the way back up to standing, and just let your shoulder blades go behind you. And again, chin to chest, rolling down, vertebrae by vertebrae, really feeling it unpeel. Then I want you to nod your head yes and no, no and yes. Yes and no, no and yes. Scooping your chin to chest, belly button into your center and curling all the way back up and roll your shoulder blades back. Then we're going to get the body moving, nice dynamic movements. Inhale as you sit back through your heels. Exhale as you pull forward. Just small little squats on the spot. Exhale as you pull forward, focusing on that stomach and that belly button pulling into your center. Exhale as you come through. Once you feel yourself starting to warm up, we're going to add a calf raise. Come up onto your toes, down through your heels, back into the squat, all the way up. Getting everything moving, waking up the back chain of your body. Inhale down, exhale up. 10 to 15 of these.
Hi there and welcome back. I hope you managed to take a quick break and perhaps do some jumping type exercises to stimulate your osteocytes. So just to finish off, I'd like to talk about some of the latest evidence around what exercises might be optimal to improve functional capacity or prevent falls. And so I just want to share with you, I guess, some evidence from a meta-analysis conducted in 2016, which really summarised the level of evidence in terms of what exercises might be beneficial preventing falls. So overall, this meta-analysis showed that exercise programs reduced the falls by about 20%, which is a modest benefit. But then they looked into the different types of exercise and they showed that not all exercises were equally beneficial. So what they did show was that moderate to high challenging balance exercises reduced the risk by about 15%. But if you did it at least 3 hours per week, you got about a 40% reduction. But what was interesting was that high-intensity resistance training or walking type programs were not effective at preventing falls. Now, as I mentioned, walking is great for cardiovascular health. Resistance training is great for improving muscle mass, strength, but it needs to be targeted if we want to improve functional outcomes. And so here's just an illustration of some of the challenging balance exercises which we often prescribe in many of our programs. And what we've designed here is a whole series, and this is just one slide, a whole series of balance exercises and progressions with different levels of difficulty. And again, you can make them more challenging by having eyes open, eyes closed, or introduce a secondary cognitive or motor task with some of these activities. But when we're thinking about trying to prevent falls, we need to understand why people fall over. And so we know that 1 in 3 people over 65 will generally fall each year. And the most common reason people fall is when they're undertaking walking and at home or during the day. But if we look at the cause of falling, loss of balance accounts for about 32% of the falls. But we also know that slips or trips over obstacles also are key risk factors for falls. And so if we're doing balance exercises, that may not necessarily improve our ability to move our leg quickly to stop ourselves slipping or tripping over. And this is part of the reason why resistance training often fails. And so if you look at this woman doing resistance training, she's doing the leg press machine in a slow and controlled movement. There is nothing wrong with the way she's undertaking her particular exercise. It's well executed. But the reality is we don't fall over slowly. And so she's training her muscles to improve her muscle mass or her muscle strength, but she's not really, training her muscles to improve her muscle mass or her muscle strength, but she's not really training them to improve function. You mean you can stop this video? And so what we've been working on and others have been working on with resistance training is trying to improve movement speed. So trying to get people to do their exercises at what we call high velocity. So we often call this high velocity resistance training, where you do the push-in phase as rapidly as possible. And there's some very nice evidence showing that if you do high velocity resistance training, so doing the push-in phase or trying to move your legs as quickly as possible during the exercise, you get better improvements in your function compared to if you do traditional resistance training. And importantly, they've shown that you don't need to lift really heavy weights. You can actually use lighter weights but do the movement phase quickly and get similar benefits. And this type of training, this power training or high velocity resistance training, has real life benefits. And so we know older people want to maintain their ability to drive their car, and they're worried they'll lose their independence if they can't continue to drive. And so several years ago, it was a very nice study which looked at the effects of power training versus traditional slow speed training and just a control group on braking speed. How quickly could a power training program or a resistance training program improve braking speed? And the findings are quite remarkable, really. So this slide shows you the changes in the performance or braking speed for those that did the high speed training versus the slow speed training versus the controls. And you can see there was a 15% improvement in the high speed group, which equated to a stopping distance of 73 metres. That is a clinically relevant improvement in sort of a real-life activity. We know that step-in training interventions are now shown to be particularly effective for reducing falls. And so here's a meta-analysis, a summary of a whole range of studies which looked at the effects of specific step-in type interventions, and you can see they observed a 50% reduction in the rate or proportion of fallers. And the increase or the reduction in falls risk wasn't really related to an improvement in muscle strength. It was related to improvement in reaction time or movement time, which really relates to muscle power. Here's some, unfortunately, videos, I won't get them to work, but there's some nice apps on the market. One called, this particular one you'll see on the video, called Clock Yourself, which highlights some step-in type interventions. You can buy this app, it's very cheap, and I really like it because it introduces stepping in multi-directional activities, but it also incorporates sort of a cognitive or motor task as well. So you're doing your step-in intervention, and you're doing a sort of a secondary task as well, which is particularly important. And this video, this app shows you a whole host of different videos, exercises that you can do and you can progress to in terms of functional step-in exercises. Thank you. You can stop the video. And there's a group up in New South Wales who are trialling a program called Standing Tall. It's the same sort of concept. They've got over 2,000 different exercises which are focusing on sort of functional movement patterns. So one of my key messages from this talk is when we're designing exercise programs, we often design them to improve our muscle strength or function, but we need to think of real life activities, what people do throughout the day. And for example, vacuuming is a classical activity from this outlier here, but it doesn't just require strength, it doesn't just require mobility, it requires all these aspects together. And so when we design our programs, think of real-life activities. Think of how we can introduce exercises which might improve, the balance, the strength, the power, the endurance, because that's where you're going to get the biggest benefits. So make them real life if possible, rather than just always on a machine. If we look at the risk factors for falls, again, it's not just about muscle weakness. These are the top 12 risk factors. You can stop the video, Yumi, that's not necessary. But of the various risk factors, you can see cognition or cognitive impairment also play an important role. And so we should be thinking for some older people to quantify or assess their cognitive function, because that might be a strong risk factor for falls. And we also know that dual tasking is a strong risk factor, or is a strong falls risk factor, and that means people struggle to do two things simultaneously. So if you remember this video of the guy walking the dog, he's trying to talk to his wife, as well as walk the dog who gets under his feet. So he's struggling to multitask. And so we know that people that can't multitask, have poorer reaction times, slower walking speed, and increased risk of having a fall. And so again, why not design programs where we might teach people to multitask? And so this is a big study we've just completed, where we looked at dual task functional power training. So here's a whole lot of different exercises that people were undertaking. We're trying to get them to do their exercises quickly. We introduced a whole host of challenging balance exercises, and we did dual task activities, whether it was with a partner or trying to balance a ball on a plate. And our whole objective was to improve dual task performance, which we did, and we also got a reduction in falls risk with this particular trial, which we'll hopefully publish soon as well. Just on this concept in terms of where we're progressing or what might be in the future, virtual reality training is growing in popularity, and this was a very nice study which looked at a virtual reality type intervention, walking on a treadmill versus treadmill walking alone, and they looked at the effects on falls reduction. And you can see here, without going into all the detail, but there was a 42% reduction in the rate of falls for those that did the walking with the virtual reality training. Now remember, the virtual reality training is a bit like dual task training. They had to negotiate obstacles or unusual walking patterns and so forth. So again, I think this won't be for everyone, but it may play a role in perhaps rehabilitation in certain settings, or even in some aged care facilities as well. The other aspect that we're working on is this concept that we can remotely prescribe exercise using new apps or different platforms through mobile phones, tablets and so forth. So there's this particular software which is relatively cheap. It's available, anyone can purchase it, called PhysiTrack. And essentially the way it works, it's got thousands of exercises in this platform. And I can sit in my office and prescribe anyone an exercise program, which then gets sent to their iPad, their mobile phone, or their computer if they like. And then when they open the app and they get the exercises, it plays a little video of every single exercise, and it tells the person they should be doing it 8 times and 2 sets. And then once the person does it, they then can provide some feedback and rate how difficult it was, and we can monitor their adherence remotely, because once they say yes, they've done the exercise, it comes straight back into my office and I can see whether someone has done it. So in a small study we did recently, here's some examples where the person was able to do, for example, a tandem walking test, and they were able to provide some immediate feedback to us where they said, I had problems with my balance in this one today, or they were doing a balance test and they wrote some specific feedback. So again, this just provides, I guess, new opportunities for people who might be remote or might not have access to an exercise physiologist, where we could at least provide some evidence-based exercise programs to them. And finally, I've spoken a lot about the benefits of different types of exercise for bone and muscle and function, but one issue which is probably an easy win for a lot of people is trying to break up prolonged periods of sitting. And so here's some nice data, some of our work and others, showing that many community dwelling people sit up to close to 10 hours per day, and people in residential aged care up to 12 hours. We did a small study showing that the longer the people sat, the much higher they were at risk of having sarcopenia. But interestingly, when we look at those people that had more frequent breaks in their sitting, so they got up and down regularly throughout the day, they had a 45% reduced risk of having what pre-sarcopenia low muscle mass. So I know we often talk about movement and physical activity, but just getting people out of their seats and moving on a regular basis to avoid these long periods of sit-in is really critical and may play an important role, be part of the package to improve health outcomes for older people. So for those that would like a bit more information around the exercise prescription guidelines, we have published a position statement recently for exercise for the prevention and management of osteoporosis. In this paper, there are actually guidelines around exercise prescription for people with different levels of fracture risk, so low, moderate, high, which some people might find useful in some example type activities. And I would also strongly recommend that you look at this particular resource. Again, it's from Osteoporosis Canada, but they've developed these videos and examples for people with different levels of risk for osteoporosis or fracture about what they should be doing. And it's a great resource, and I'd strongly encourage you to perhaps look at some of these in the future. And finally, if anyone's got any questions or would like any additional information outside of the webinar, I'm certainly happy to assist you or provide you with some of the resources, and here are some of my contact details. And thank you for listening.
Rob, that was an amazing presentation. It was just so comprehensive. Very quickly, we've got just a very quick couple of questions. The name of the app again with the clock face, was that Clock Yourself?
Yes, that's correct, Clock Yourself.
Yep. Okay, another question was in relation to an interesting question. What percentage of your older patient population have a preference for using phone apps? Yeah, your comment on that?
That's a very good question. Look, in the small trial we did, we actually did people who had previously experienced or have a phone app or a tablet, and those that didn't. And overall compliance was similar through both of them. But the longest trials that have been done to date are only up to sort of 4 months with using technology. And so it's a difficult question to answer. I mean, I think we know that about 80% of older people now have some sort of technology, but or phone, you know, a tablet. But I can't really answer the question how many would be willing to use it in the long term.
And one final question before we finish. How can we encourage younger men and women to start thinking about the importance of muscle and bone health when it's really not within their mindset when they're in their 30s and 40s?
Look, absolutely, and that's a really important question. And to be honest, I think we need to be starting earlier as well, especially in the children for bone health, because the only time in life where you can really improve your bone health is in the first, basically, 20 years. And then I think what we need to move to is once we hit around 40, I think we need to be, or doctors need to be starting to consider aspects like sarcopenia or functional assessments or even fitness assessments as part of routine care, like you're getting your blood pressure done, like you're getting your lipids done, because once you can identify a weakness at an early age, you can then intervene.
And just quickly, Rob, any other particular physiotherapists, exercise physiologists that have been actually trained in some of these specific delivery of some of these particular sort of methods and so on, or basically it's really up to any sort of practitioner to adopt your information tonight?
Yeah, look, it's a good question. I mean, obviously physiotherapists, many of them are trained in musculoskeletal type conditions. Whether they're trained specifically to do osteoporosis, specifically exercises for improvement, is questionable. Many of them probably are. And exercise physiologists, again, some of them would be very highly trained to prescribe exercise for people with osteoporosis, but some of them might specialise in people with type 2 diabetes or, you know, cardiometabolic type conditions. So, again, I can't really answer that question. There are, I know there's, in Sydney in particular, there's a very active group that promote osteoporosis exercises. But again, you could probably search on the ESSA, Exercise Sports Science Australia website, and if you type in your postcode, you might find people who are specialising in musculoskeletal conditions. Okay,
on that note, we're just a tick over 8 p.m. So again, Rob has made that generous offer. If anyone has any additional questions, to email him, which is a very generous offer. Look, I'd like to thank you again, Rob, for a fantastic presentation this evening. I'd like to thank everyone for joining the webinar tonight, particularly and also to Peninsula Hot Springs for allowing it to be available free of charge this evening. The film of the recording, you'll be receiving the recording and the a PDF of the presentation. A link to the recording will also be available on our website within the next week. So look, on that note, I do ask everyone if they could actually complete the exit survey, which is on your screens now, and also remember our last health professional webinar will be on Tuesday the 27th of November, and it's on the topic of fibromyalgia. So on that night, thanks again, Rob, and good night, everyone.